All right. Hello and welcome to Seeing Through the Masks, Access During the Pandemic. My name is Emma Wood, and I serve as the Assistant Dean in the College of Education. I will be your moderator for today's conference. This conference is the result of an interdiscipline interest in addressing access for deaf and hard of hearing individuals in the community. The conference planning team is excited to announce there is participation from coast to coast and at least 9 states are represented. We have a special thank you to the ISU Cultural Events Committee for sponsoring our keynote speaker today. Additional thanks to the Department of Community and Public Health, the College of Education, our interpreters, captionist, and of course, our deaf presenters. Want to give a special thank you to the Albion Center for Professional Development, who is providing us with the opportunity to offer continuing education credit for this conference. To qualify for credit, please stay for the whole conference, answer the presenter feedback polls, complete the final evaluation, and commit to apply your learning. Further directions will be emailed after the conference. We need to take a few moments to address protocols for this conference and Zoom etiquette. I will be moderating and I will use spoken English. The 3 presenters will use American Sign Language. Interpreters will sign or voice as appropriate. Live captioning is also available and can be shown by clicking Show Subtitle in the Zoom toolbar. You can also adjust the settings for the size if you'd like. If you have any questions for any of our presenters, please send them to me through the chat window directly. During the Q&A sessions following each presenter and the final Q&A panel, I will be asking questions that have been sent to me based on the time available in the schedule. I would encourage you to attend the final panel discussion as there will be more time to discuss your questions then. And for your information, all videos will be stopped and microphones muted to prevent interference with the presentations. It is my pleasure to introduce our first speaker. Stephen Snow currently serves as the Executive Director of the Idaho Council for the Deaf and Hard of Hearing. He oversees state-level programs to assure accommodation, access services, and recommends public policies for the deaf and hard of hearing citizen. Stephen has served and continues to serve on many boards and committees that support community access for Idaho's deaf and hard of hearing citizens. Mr. Snow recently co-authored with Elizabeth Schneiderwind and Ryan Lindsay a publication on the discrepancies of services for the deaf and hard of hearing in the medical sector. Please welcome Stephen Snow.
Well, hello, everyone. Thank you, Dr. Wood, for that introduction. I apologize if my video is out of focus. I'm going to try to stay in the same spot, so hopefully it'll stay in focus for you. I'm now going to share my screen. All right, just one moment, having a few technical difficulties. I apologize. It seems that my PowerPoint has crashed. Give me just a moment to open that again. I apologize. I will be right back. I'm going to try to quit and come back in and see if that works. Okay, there we go. Hopefully you can see my PowerPoint now. I apologize about that. Of course, out of all days, it's today that my PowerPoint wouldn't work. All right, I'm going to set a timer so that I don't talk too long here. I'm so honored to be presenting to you as your keynote today. I wish we could meet in person. I love being able to see the audience and connect with you on a personal level, but the next best thing for now is remote. So I'm happy that we at least have that option today. Today, I'm going to discuss access and barriers among deaf users of American Sign Language in healthcare. During my presentation today, I'm going to discuss the research that was conducted, and I'm also going to tell you some of my journey and my experiences with healthcare and what access has looked like for me personally. Before I proceed, I would like to show you a few pictures. I want you to take a look at those and think about how you feel when you look at them. So on the surface level, this picture looks very nice. It looks like a nice picture of a doctor and a patient getting cozy and discussing a medical concern. It's a nice picture and a nice thought. Unfortunately, I can't relate to this. I can never think about my interactions with a physician being like this. Many deaf people feel the same way that I do. They don't have that personal and private connection with their doctor. There's just no chance that that would be something that I could ever envision for myself. With a sign language interpreter, there's always a third party in the room, and there's often miscommunication, and so much of my attention is put on that communication instead of on the issue I'm there for. So that picture looks great, but it's not necessarily what I experience. My picture looks more like this. In my experience with healthcare, I felt that information is in a fog. I felt frustrated and like I wasn't getting the whole message. This is what many and most of deaf and hard of hearing users of American Sign Language feel when they interact with healthcare professionals, unfortunately. Now I'd like to share my journey and a few of my personal experiences and interactions with the healthcare system during my life. So this is my perspective as a deaf person. My relationship with any healthcare provider takes a laborious amount of effort to ensure that information is getting across appropriately. I have to consider if an interpreter is qualified or not, or if there isn't an interpreter, and if the doctor speaks, I have to try to figure out a different way to communicate with them. When I arrive to the clinic for my appointment, I already have a fog looming in my head, thinking about what to expect during that appointment and what that interaction will be like with that medical care provider. I grew up in a small town in Gooding, Idaho. And being a rural town, there were probably only 2,500 people there while I was growing up. It's grown some since then, but it's still quite a small town. And that's where the School for the Deaf resides. As you can imagine, with any small Idaho town, there aren't specialists like pediatricians or primary care physicians. Typically, it's a one catch-all system. So there were only a few doctors in the entire town. So this was the doctor that my family chose growing up for me, and that was Dr. Smith. This was the only picture that I could find of him, and unfortunately, he passed away last year. My parents and my brothers and my sisters and myself all went to this same doctor. The only communication I ever got from this doctor was a thumbs up, a thumb sideways, or a thumbs down. I remember going as a young kid, and I remember him checking my heart rate with a stethoscope, and he would check it and he'd give me a thumbs up. And then he would do various checkups, and he'd give me another thumbs up. And he would press on different parts of my body. And then for communication, he would have me give him a thumbs up, a thumb sideways, or a thumbs down. And at that time, I thought that's how doctors communicated with everyone, including people who could hear. I thought they only used this thumbs up system. So that was my experience growing up, interacting with healthcare professionals. I really didn't have a conversation with him that whole time. When I look back, I think about how much I was missing in those appointments and how much I could have discussed with him. So this was my experience with my primary care physician. So I call him my thumbs up doctor. After I graduated high school, I did not seek healthcare or see a doctor for 9 years. I honestly felt that the system of thumbs up and thumbs down wasn't valuable in my life, and I didn't see that there was a valuable connection there. Fortunately, I was young at the time, and during college, I was mostly healthy, and it wasn't until 9 years later that I found another primary care physician. So my experience growing up not having communication with my doctor, that caused me to delay my care. And it really wasn't until 9 years later that I took my healthcare seriously. During college, I didn't have a primary care physician, and I also didn't have a dental care provider. It wasn't until I was hired in a full-time position and had healthcare insurance. I realized I hadn't been to the dentist in over 9 years, so I knew I was overdue for an appointment. So I sought out this dentist, Dr. Stephen Ratner. Dr. Ratner is a deaf dentist. I have to say, that experience was amazing. For my first appointment, I remember going in and being able to sign directly with my doctor. When I walked in, the receptionist also knew sign language, and the dental hygienist knew sign language as well. Growing up, my experience going to the dentist was a lot like my experience with the doctor. I would open my mouth and the doctor would put strange metal contraptions in my mouth, and I didn't know what they were for. I just was a good boy and did what they were gesturing and never had any communication with them. It wasn't until I had a deaf dentist that I was able to ask him what all of those metal tools were used for. He was able to explain that one of the tools that they used was for measuring gums. And I asked him about another tool, and he was able to fully explain it to me in American Sign Language. And it was like a light bulb went off. I never had that kind of interaction with a dentist before. At that first appointment with Dr. Ratner, He told me that I had very sensitive gums and that I needed treatment, and I had never known any of that. I did not fully understand dental care and the health of my teeth until this appointment. This was the first time in my life where someone who used American Sign Language could fully explain dental care to me. After that, it made me look back on my experience and think about all that I had missed from my previous appointments. I saw this dentist for several years until I moved back to Idaho, unfortunately, and he stayed on the East Coast. Even though I don't have a deaf dentist here now, because of my experience with Dr. Ratner, I have that built experience and that knowledge that I can draw upon for my current appointments. I've kind of always had bad eyesight. I would say you could call me legally blind as a bat, but I've had glasses since the age of 6. So I've gone to regular optometry appointments ever since then. I remember that they would always pull up this contraption to my eyes and they would puff air into it. And then they would use other contraptions to measure my eye. And I didn't know what it was for. It wasn't until I moved back from Washington, D.C. to Boise, Idaho several years ago when I met Dr. Terry Walker. Dr. Terry Walker is an optometrist who uses sign language. He himself can hear, but he used to be an interpreter, so he's fully fluent in sign language. And it was at that appointment that I could ask him what those measurements were for, what the puff of air was for, and he was able to explain it to me. So I had a wonderful experience with a dentist, with an optometrist, and unfortunately, I haven't had an experience like that with a primary care physician, but I have been able to communicate with them through interpreters, which is the next best thing. But it's because of my experience with Dr. Walker and Dr. Ratner that I had full communication, was able to better understand my healthcare. Unfortunately, Dr. Walker has since moved to Utah a few years ago, which is quite disappointing for me. But I really do cherish the time that I had with him in those appointments where he was able to explain everything to me so clearly. So that is my experience interacting with healthcare professionals. And I'm not alone in this experience, unfortunately. Many deaf people have very similar experiences. And honestly, many of them have experiences that are much worse. So now let's delve into the issue of this: access to healthcare for deaf individuals. I'd like to discuss what the barriers are to healthcare and why those exist. Anecdotally, we have heard stories of people struggling to receive healthcare, but we haven't had the research in the past to show that their stories are valid and that is truly happening on a larger scale. When I moved to Boise, I accepted the job as the executive director at the Idaho Council for the Deaf and Hard of Hearing. Within that, we address many issues that deaf and hard of hearing people experience, and one of those that we address often is access to healthcare. At our office, we have received many complaints and concerns from community members expressing their issues with access, whether that be in regards to interpreters or other issues. And we've noticed a pattern that many of those issues are related to access to healthcare. Since 2008, when I started working here, we've received many complaints that clinics and offices wouldn't provide interpreters, and we have done outreach and education to inform them regarding the laws that pertain to them. We also began collecting data on how often we receive these complaints, starting in 2012. We collected this data for 5 years. During that 5-year period, we collected 108 complaints related to healthcare. We know that these aren't the only issues across the state, that there are many that go unreported that we're unaware of here at our office, so we can't provide our assistance. I want to thank Idaho State University and their research analyst who helped us to analyze this data and to recognize this trend and this issue that people were experiencing in regards to healthcare. I'll now explain a few of the instances a few of the complaints that we received. I'll share 3 stories of actual complaints that happened here in Idaho. Again, there were many that we received, 108, but I'm just picking 3 to highlight today. This specific complaint occurred in Nampa. There was a clinic that would not provide a sign language interpreter to a deaf patient for many months. That patient's family decided to transfer their care to another clinic where an interpreter was provided. Before that, the patient had been misdiagnosed many times, and it wasn't until they transferred care that they finally received the correct medication and the correct treatment to help them recover. This is a common issue. Here's another instance of one of the complaints we received. This happened in Meridian, Idaho, so just outside of Boise. In this instance, the mother of the patient was deaf and the child could hear. And this mom who was deaf felt that there was something wrong with her child, and so she took her in to be seen at the clinic. But they would not provide a sign language interpreter. And this mother tried to explain the issues that she knew that her daughter was experiencing, but the doctor took a look at the patient and said, well, it could be this, or it could be this. But because they would not provide a sign language interpreter, the deaf mother did not have access to this. It wasn't until her child's situation progressed that they had to go to the emergency room where they finally provided a sign language interpreter. And the mother was able to express the entire experience. And it wasn't until that ER visit that they were able to discover what was wrong, and they were able to prescribe the treatment that was a life-saving measure. This third complaint was received from an instance in Twin Falls, Idaho. The patient went in complaining of lower abdominal pain and needed to have an appendectomy. There was not an interpreter provided for this surgery, so they were rushed off to surgery and then released. And it wasn't until they woke up that the deaf patient lifted their gown and tried to look for the incision wound, but only saw a very small piece of tape on their stomach. There was no one that explained to them what the surgery was before they arrived. And it wasn't until after they were discharged that they got home and they wondered if a surgery had even been performed. So they were able to call through video relay service, and the healthcare provider explained that they were able to remove the appendix through a small incision in the navel. So they weren't going to have a big scar on their stomach. Unfortunately, none of this was explained to the patient beforehand. Instead of the doctor taking time in that instance to explain the situation to the patient, they just waved them off and discharged them. So these are just a few examples of the complaints that we received in our office during that 5-year period. Here is an analysis of those 108 complaints that we received. Of those 108 complaints, approximately half said that when they called to request an interpreter, the office would provide them. However, approximately half of these, once they arrived, there was an issue regarding the interpreter. The other half, the 48.2%, when they requested an interpreter, the office said that there wasn't an interpreter available, and they took no precautions in order to secure an interpreter for that appointment. Another statistic shows that almost 29% of these offices said that they would provide an interpreter, but upon arrival, there was no interpreter provided. Upon arrival, the interpreter that was provided was not qualified and was incompetent. In 18.5% of these complaints, there was an interpreter promised, but there was not one provided upon arrival. 4.6% of the time, the patient was told by the clinic that their insurance was not accepted. The patient felt that this was an excuse for not providing an interpreter. Instead of telling them that they wouldn't provide an interpreter, they believed that the clinic just told them that their insurance wasn't accepted, even though it probably would have been. They were also told that they were not accepting new patients. From this research, we shared our findings with Dr. Elizabeth Schniedewind. And from that, we were able to establish a new research project, a simulated patient study, to really delve into the issues that we received from these complaints. We worked with a wonderful team, including Dr. Schniedewind. She was the lead researcher on this program. Dr. Ryan Lindsay, who is well-versed in numbers and analysis, also worked on this project. And this was published in the Journal of American Medicine Association, which was a huge accomplishment. I'm not going to delve into too many of the details, but I'd like to share with you a few instances of the study and the results that we found. Now I'll explain the design of this study to give you an idea of how it all got started. Once we decided to conduct this study, we knew that we needed to collect a sampling group of doctors' offices and dental offices. So what we did is we collected a list of licensed primary care physicians and a list of primary dental care providers. For this specific study, we decided to focus only on primary care physicians and dental offices instead of on specialists and other offices. So from that, we collected a stratified random sample of 445 providers. 75% were primary care providers and 25% were dental care providers. At that point, we selected a total of 8 simulated patients or research assistants. Of those 8, 4 of the individuals were deaf and 4 could hear. Of the deaf simulated patients, 2 were male and 2 were female. And of the patients who could hear, 2 were male and 2 were female as well. We then asked these simulated patients to call all 445 clinics to request a new patient appointment. These simulated patients are also referred to research assistants. We gave these research assistants a script that they would use when they called to request a new patient appointment. The only difference between these two groups was that the deaf simulated patients used the video relay service to call through a sign language interpreter when making these appointments. All of those calls that were made by the deaf patients were recorded, both video and audio, and the audio was also recorded for the simulated patients who could hear. The total number of calls that were made was 1,092. So you may be wondering why we only had 445 clinics, but 1,092 calls. The reason for that was because the research assistants had to make several follow-up calls in order to attempt to secure an appointment. We also ensured that all of the research assistants had a phone number that was a 208 area code. The reason for this being that if they had an area code that was in California, for example, they may be screened out of that initial process by the person who's working the phone at the office because they might have thought it was a scam call. So because it was a 208 number, we thought for sure that it would get through that first initial screening process. Now I'll show a map of where those clinics were selected across Idaho. As you may have guessed, most of the clinics that were selected were in the Treasure Valley. The remainder of the clinics are along what we call the Banana Belt, so Twin Falls and Idaho Falls, and we also included clinics in northern Idaho. Within that, we had 3 demographic locations: urban, rural, and the final category was frontier. So these refer to those very small towns in the middle of the mountains, really in the middle of nowhere, so beyond rural, but frontier. So those were the demographics that we selected. So after we had the research assistants make those calls, what did we learn? Not to our surprise, we found that deaf patients were less likely to secure a new patient appointment than patients who could hear. And this is something that we have heard about for years within the community. But through this research, we finally had the data to support their claims. It wasn't just a few people making noise, but now we have the data to show that deaf people are being discriminated in this realm. With this research, we found that the anecdotal data and this data through this research project coincide. We found that patients who can hear were almost 2 times more likely to be successful in securing a new patient appointment than patients who were deaf. One interesting thing that we found through this research project was actually through one of the research assistants who was deaf and actually happens to be my wife. So at the conclusion of this research, my wife felt very angry and very emotional. And I remember her coming to me at the end of the day and asking, why would they do that to us? Why would they discriminate against us in that way? And I tried to help her feel better by explaining, we're just going through this for the research project. But she really took it to heart and it felt very personal. And we spoke with the other 3 deaf research assistants in this project, and they all had that same reaction. Through this research, we found that approximately 48% of these failed appointments occurred because these deaf patients requested a sign language interpreter. So approximately half of the time, the reason why they were denied an appointment was because they had requested access. Here's another interesting finding from our research. Historically, we have always encouraged deaf individuals to practice self-advocacy. This means that we've encouraged them to request an interpreter and to continue to educate those clinics when they're requesting an appointment. During our research, those research assistants made follow-up calls to request an interpreter, and we found that the more times they called, the less likely they were to be successful in securing an appointment. We found that when they would initially call and request an appointment, they might have been granted one, but then if they followed up by saying, by the way, I need an interpreter, the staff person that they spoke to often made an excuse and would cancel the appointment. We know that the deaf community has to self-advocate in so many realms. So to have to do it again in the medical setting, for it not even to be successful, is so exhausting. Another interesting finding, which may be quite surprising and honestly, maybe a little disgusting is this. Our research found that even though our simulated patients who were deaf and our simulated patients who could hear had the exact same insurance, when our patients would call, oftentimes the hearing patient's insurance would be accepted, but the deaf patients were told that their insurance wasn't accepted, even though this insurance was the exact same and they were calling the exact same clinics. This means that those clinics were trying to hide their act of discrimination by making up the excuse that they didn't accept the insurance. So our research shows that it really isn't that they don't accept the insurance, but it's truly just a blatant act of discrimination. I could delve into so much more on this research, but I won't keep you too long. I know that you all aren't researchers, but I just want to give you an idea of those findings that were quite surprising from our research. Or excuse me, it honestly was not that surprising because we've seen that happen again and again through those stories that we've heard. Another study that was conducted by the National Institute of Technology for the Deaf and the University of Michigan found this. This research by NTID and the University of Michigan found that deaf individuals are 7 times more likely than their hearing peers to have heart disease, high blood pressure, and strokes. This is just shocking. When I look at this, I try to think why, and I have some thoughts as to why it could be, but we really need to conduct more research to show that our inklings and our feelings as to why are true. That hasn't been conducted to this point, but we're hoping that more research will be done in the future. This is heartbreaking that deaf individuals like myself are 7 times more susceptible to heart disease, high blood pressure, and strokes. This shows that something is wrong with the system. I'd like to share another image with you at this point. I want you to imagine this iceberg as the deaf community interacting with the healthcare system. As you can probably guess, of the deaf community, everyone has their individualized experience with healthcare, with the healthcare system, but I've categorized them into 4 categories. The first category, the very tip of the iceberg and the cream of the crop, which is, as you can see on this picture, a very small percentage. It's this percentage that have complete access to their health care. It could be that they see a physician who signs, or that the clinic is well versed in interacting with deaf patients, and they have a very qualified staff of sign language interpreters. It's only a small percentage of deaf people who have this perfect access to their healthcare. The second group represents the larger portion of the iceberg that is above the surface. And this is people like me. I've had experiences with appointments where the interpreter is incompetent and unqualified. I've had experiences where I've tried to interact with my doctor without an interpreter. It may be that I have had to fight for them to provide an interpreter, and they finally have, but it's not without its struggles. So that is another percentage. And then the third group is that group that is below the surface. This is the group that we often don't see. And this is the group that our research primarily focused on those who requested appointments, but were often denied. This is the group of deaf individuals who have been denied interpreters and have had to try to go to these appointments and just get by with what they can, or have just taken what they can get from the doctor's office, even though they won't provide accommodations. Instead of fighting the system, they haven't had the education in order to maneuver that, to move their way up above the surface and into that second category. The fourth category are those that say, why bother? And this is very saddening. And that's the group that breaks my heart. These are the people that would rather suffer with their pain than have to try to navigate the healthcare system. They know that it's not going to be worth their effort, so they don't even try. I was a part of this category when I didn't have a physician for 9 years after high school. I didn't think it was worth it. And I would say that the largest percentage of people are in this category. They feel that pursuing healthcare is not worth it. They would rather live with their pain and live with their problems than seek care. And it's this category that relates to that research that was conducted by the National Institute of Technology for the Deaf that shows that deaf individuals are 7 times more susceptible to healthcare issues. Deaf individuals, myself included, deserve to be accepted as patients. There's no question about that. We deserve to have full access and full communication with our healthcare providers. It shouldn't have to be a battle, and it shouldn't have to be something we have to navigate through. Our system needs to change. And there are many possible solutions. One being training. And we have conducted some trainings with some medical schools, but more needs to be done. There are many possible solutions for this issue. From my perspective, the best solution, and probably the long-term solution that will take the most work, is well summarized in a quote from my good friend. This quote says, "The first law of medicine is to do no harm." Don't we realize that by not providing proper communication access to those that need it, we end up unintentionally harming them? Hence, the dire need of diverse physicians, including deaf physicians. If we had more deaf doctors and more doctors who could hear but could sign, more doctors like Dr. Walker and Dr. Ratner, that would change the experience for many deaf and hard of hearing patients. There's no question about that. I want to again say thank you for this opportunity to present on this research that was conducted. I'm hoping that this research that was printed in JAMA will then lead to further research, and we're able to take a deeper dive into those levels of that iceberg. There's so much more under the surface that's just waiting to be discovered. And there are many layers to this issue. I'm hoping that through that research, we can begin to see a systematic change in the healthcare system. So this concludes my presentation, and now I'm open to any questions.
Well, I first want to say thank you so much. That was very informative. And I think that shock-faced GIF gave my reaction perfectly. To recognize that there's a 2-to-1 ratio in securing an appointment, and that's a huge discrepancy.
Absolutely, yes. Yes, is very unfortunate.
And so there was one question that came in regarding the patient that had the appendectomy. And that question was, wouldn't the patient need to sign an informed consent for surgery, provided that they were awake and alert?
Well, that's a great question. And this actually brings up a very serious issue. Many deaf patients are handed written instructions and they're told to sign them. And so they just sign where they see the X on the paper without even reading it. I would say a large percentage of those people who do that don't know what they're signing. If clinics would take the time to interact with their patient and say, will you sign this? But before you do, will you tell me what this means? That is so critical to ensure that their patient understands what they're signing before doing so. What we see happen so often is that someone just shoves a clipboard in front of them and says, we need you to sign this right now, instead of actually taking the time to ensure that their patient fully is aware and understands that information.
Here's another question. What can hearing individuals who work at the bottom level, such as receptionists, do to aid deaf and hard of hearing individuals in the workplace and specifically the medical field?
All right. Would you mind repeating that question? I'm sorry, the chat popped up right over the interpreter as you were asking that.
What can receptionists do if they're the ones answering the phone to help the deaf and hard of hearing individuals?
Again, that's another great question. It's important that all clinics have a set protocol and guidelines for these receptionists. So for example, they should have it in writing on how these receptionists can accommodate and provide these accommodations like sign language interpreters. One of the greatest issues that we see is that there is a high turnover rate for these frontline staff. Instead of having to reestablish a protocol every time someone is hired, the clinic should have a set of guidelines that an individual can refer to when they receive a call from a deaf patient. This way, when a deaf patient calls, they can just flip to the right page of that protocol and they're able to accommodate them. Some clinics have those and some do not. We've noticed that typically larger systems that have multiple clinics have this set of procedures, but most small independent clinics do not have this yet. It requires awareness and training at the higher levels in order to establish something like this, but we highly encourage that people do that.
So for those frontier physicians' offices, what resources are available to provide interpreters if there aren't any that live in the vicinity?
From my experience with those frontier offices, we've only had a few of them, maybe 2 or 3 that have reached out to us to help them resolve that issue. Fortunately, with technology these days, we have options like video remote interpreting. So if an interpreter is not anywhere within a 100-mile radius, these clinics would be able to connect through a sign language interpreter through video capabilities. I do want to caution everyone, though, that that is not befitting for every situation, but in some situations, that is a workaround.
So have you seen clinics or hospitals utilize tablets or whiteboards to communicate? And what's the effectiveness of that strategy?
Yes. Well, my answer is it depends. I would say that clinics should not assume that deaf individuals can read and write English. For many people who are deaf, English is their second language. Especially when we're considering healthcare, when an individual is entering an environment that is quite intimidating. They're already in pain and they already are so focused on that that they are less able to concentrate on trying to communicate in their second language. And that's why providing a sign language interpreter is such a great accommodation. I also want to remind everyone that access is not a one size fits all, and it's not a one-way communication. An interpreter is provided for the deaf person to be able to understand, and it's also provided for the healthcare individual to be able to understand as well. So it's not just that the information is being passed from the healthcare provider to the deaf patient, but it goes the other way too, from the deaf patient to the healthcare provider. So when clinics are considering what accommodations to provide, I want them to consider that communication needs to go both ways. It needs to be a two-way street. And so the accommodation of a sign language interpreter would be the most effective way.
And here's our final question. I want to be a nurse. Is it worth learning ASL even if I'm not at an interpreter level of communicating?
Wow. I'm so glad that someone brought that up. I was planning to mention that during my presentation, and I don't think I did. So that's a great question. In our audience today, we have several students in various fields within the healthcare setting. If I could communicate with you directly as a patient, that would make my day. That would be the best option. And even though you may not be equivalent to an interpreter, I would encourage you to take several classes. So it's not just the basic ABCs that you know, but I would encourage you to take those classes and to get involved with the deaf community. It will open your world. And that will help you develop a wonderful rapport with your deaf patients. I highly encourage, if you're able to take sign language classes. If you have the time, 100% do it. I do want to say that with a caveat that if you are still learning sign language and you may know some basic signs, still provide a sign language interpreter. Still bring in that person who's fluent. So then you're not gambling on anything. And it may be that from then on, after having that interpreter there one time, then we can communicate directly.
I want to thank you very much, Stephen Snow, for your presentation. And we are going to take a break and restart at 2 o'clock. You will see a poll show up. And so please, those of you who are participating, complete that poll, take your break, and we'll see you in 5 minutes.
Wonderful. Thank you.
All right. Welcome back, and anyone joining new, I'm Emma Wood, your moderator, and live captioning is available by clicking Show Subtitle in the Zoom toolbar. And if you have any questions for our presenters, please send them through the Q&A button. And during the Q&A session, following each presenter and the final Q&A panel, I will be asking those questions that have been sent based on the time available in our schedule. And I would encourage you to attend the final panel discussion, as there will be more time to discuss your questions there. Stephen Stubbs is a certified deaf interpreter in the state of Idaho, in addition to his faculty role in the interpreter training program here at ISU. Stephen has also demonstrated leadership with service on state boards related to the deaf and hard of hearing. Many of you may recognize him from his role as an interpreter at the governor's press conferences during the pandemic. So please welcome Stephen Stubbs.
Thank you, Dr. Woods. I really appreciate that introduction. I like to start with a funny story where somebody last Tuesday told me about my shirt, and so I had been practicing to make sure that everything was right. And then today, when we were meeting before with Director Snow, we had the same color tan shirt that day. And then today, without planning it again, we both have a red shirt. Something in the air. So I want to make sure that everyone here can see my PowerPoint. Is that working all right? Okay. And
yes.
Great. Okay, excellent. Okay, great. Good to know. I just, yeah, the response helps. So what I'd like to talk about today is a topic that has research about medical providers that do not provide interpreters. It's not that we're looking at that as much as we do hear these complaints. That it's not that they don't necessarily want to, but the fact that the interpreter service itself is costly. And so that's what I'd like to take a deeper look at. Because I want people in the audience to understand that it's possible that providers have never experienced working with a deaf person before in their lives, and really perhaps have not even met a deaf person. And so in opening, I'd like to start with some information that supports that. So let's talk about the demographics of deaf people. That's what we're going to talk about today. We're going to talk about interpreting, not at a college level, so we'll call it Interpreting 050, just barely scratching that surface. But then also, we're going to talk about what undue hardship is and what it means when people say that the service is too expensive. So some of the numbers that I'm going to be giving you at this point are not numbers that are hard and fast. It is really, in many cases, educated guesses with research behind them. So when we start that, it is that it's about 2 to 3 out of every 1,000 children in the United States that are born with a detectable level of hearing loss in one or both ears. And in the larger group of society, American adults, 15% of those people have some level of difficulty hearing that they report. Now, we're going to talk specifically about Idaho. And for our purposes, an estimate of about 1.7 million people have a hearing loss. And that number comes to us as recently as July of 2018. Out of that 1.7 million people, 25% of those are children. And when you break that down further, because of that 2 to 3 out of 1,000 number, you're talking about 1,300 or so children who are born with some level of hearing loss. Now, that number doesn't include the largest numbers of people who have hearing loss, which is a group of people who get that later on in life. There's groups of people who have hearing loss because of the onset of an illness. There's also people who have a hearing loss that begins at puberty. The Idaho Educational Services for the Deaf and Blind collects data of those who qualify from ages 0 to 24 years of age. And their hearing loss is such that it requires additional levels of support. So there's a severity factor in the reporting as well. Now, from those numbers, you might see that there's a larger percentage that seems to come up after the age of 18. And so we have that 15% number of people who have a hearing loss that are not in the group of children. So you're talking about 200,000 people of adult age that have some level of hearing loss. The causes vary widely. Sometimes it's occupational exposure to noise that damages their hearing. Sometimes there are ototoxic medications. And then there is natural progression due to age in hearing loss at times. There are hearing loss as a result of traumatic brain injuries or other specific diseases or conditions that can cause that. Thanks. And so the point of that is if you are working with children, and if there is a group of, so for example, 200 children that you work with, one of those children will have a hearing loss. Now, if you're working with the adult population in your practice, for each 7 patients that you have, one of those will have a hearing loss. So that's the demographics and the numbers that you're going to be seeing. So when you're in a service provider industry, which healthcare, of course, is, you are going to encounter individuals who have some level of hearing loss during the time of your practice. And you can assume that is going to happen, even if in your past experience that has not been the case. You will encounter people that have a hearing loss, regardless of whether you have or not in the past. There are some other groups of people that you're going to encounter that I haven't mentioned in great depth yet. Individuals with speech disorders, for example, or also individuals who have intellectual or developmental disabilities. These individuals have additional communication challenges at times. So if you think about the 200 child level patients and then the adult patients, if you include also people who have challenges in communication in general, that's going to bring the numbers up from what I previously said. So now that we're looking at interpreting, because we have looked at these people who have a hearing loss, You are going to have to be prepared for that because no question you will encounter people like that. So how will you provide communication access to all of these individuals that you will most surely see? In general, the majority of these individuals utilize some kind of assistive listening technology so that their ability to hear things can be enhanced. Now, when they use those devices, oftentimes there's a thought that that completely mitigates the problem at hand, but that's not necessarily always the case. It can improve communication and the ability to appreciate that, but a measurement of full and 100% access to communication is not something that we know is happening at that point at all times, but that it can provide some improvement. Some of these individuals decide to use hearing aids, and it is effective for some of them. Then there's also individuals in some situations, for if it's a larger group, for example, they would request captioning services. There are some people who will ask for light indicated signals or things to be to have the sound turned up. Really, there's a wide variety of options of assistive listening technology to help people in these situations. So Stephen Snow, the previous presenter, has a program in the agency, and they work with different locations in Idaho and partner with organizations that work with senior citizens as well. And they also explain assistive hearing technology that's available. And if that's something that you would like some more information on, please feel free to contact CDHH, as they have a wide range of experience on that and a lot of expertise. So oftentimes we hear people talking about cochlear implants, and there is a belief, and we are told many times, that cochlear implants solve the problem of needing to be able to hear better. Cochlear implants are a device that are placed, that are a medical appliance in someone that has an electrical simulation of sound that can improve a person's ability to understand speech. However, it's not always something that is able to be guaranteed or always know that that's the case. There are individuals who definitely benefit from cochlear implants. It's not a solution that is 100% effective in all situations, although it can be in some. Let me just bring this forward. So some of the issues that can come up with cochlear implants that I'd just like to touch on are the fact that if there is environmental noise, a cochlear implant oftentimes, because of the way that it's set up, will filter out some of the background noise. However, if there's many people that are speaking in an environment, for example, a meeting, if something is occurring in a restaurant where there's a lot of conversation, the ability of the device to filter out other conversations or other speech does make it challenging at times for cochlear implant users to have full understanding. And so the environment where the use does make a difference. It is optimal if you can have one person at a time speaking when there is a cochlear implant user, because it makes it easier to appreciate what the person is saying. The other important point is that people oftentimes are not wearing their implants. People take off their implants to take a shower. There are times throughout their day where they do not use the cochlear implants. And so at those moments, they are completely unable to hear many times. Something else to think about in terms of cochlear implants is really the way that sound is processed in the brain actually is different than without devices. And because of that, there is a great deal of training necessary to be able to decode all of the stimuli received through the device and through the implant. There is a great deal of articulation and speech therapy that often is needed in concert with the use of CIs. And there are many people who feel that that is certainly worth the time invested into it. There are others, many that we are personally aware of, that have had implants and who have told us over time that they had wished that they would have been able to have more time exposed to academic subjects in the classroom, such as science or English. But instead, their time was spent on other kinds of training, which left them at a loss and a disadvantage in terms of keeping up academically. Many times they weren't able to participate in extracurricular activities or even to socialize with their friends because the speech therapy and other kinds of training was prioritized. It is a trade-off that people have to be aware of. And it is what it is, for better or worse. Another point is that cochlear implants are quite expensive. They range between $30,000 to $50,000 for a unilateral implant. If it's a bilateral implant, figures have been quoted as much as $100,000, and certainly more than, say, another significant expense in life, like a car or something like that. Now, if a person had an implant and then later on the device was damaged, what does happen at times is that they are not able to replace the technology until it falls in line with the schedule of replacement provided by the insurance company. So if it is the case that they have to do that, sometimes they're at a disadvantage too. And there is limitations sometimes to the amount of training or speech therapy that insurance will cover. And then there are the supplies, the consumable supplies, such as batteries, that go along with those devices that also sometimes are not reimbursed. And so there are costs associated with those as well. So that's something that also should be considered when someone's deciding, especially families, about whether or not it's going to be something that's workable. And many times people have those expenses taken care of for them when they're younger, but then as they become adults or young adults, their ability to afford something like that is compromised until they come to a better position in life. And so it's that time in there when sometimes it is more challenging, and that should be considered as well. Not everyone is eligible for implantation for a variety of reasons. And also, sometimes they are ineffective for certain individuals. One of the most concerning aspects to us is the fact that cochlear implant manufacturers and those health professionals describe the benefits to parents and oftentimes make guarantees of success of the benefit of that procedure, which at the time sounds very impressive. And if it were true, it would be wonderful. And it would be great to see the numbers and statistics that support those statements. So for example, even a child as young as 6 months, if we had complete longitudinal data about whether or not the surgery was successful, as well as the training, and then what we could expect and have benchmarking in terms of what's happening in classroom environments, when it works. But that information is not publicly available. We don't know what implant recipients have in terms of expectations for percentages of success of understanding. The cochlear implant manufacturers, who are approved by the Food and Drug Administration, they have had data that has been collected all along. Requests have been made to share that data with members of the public, and it has been repeatedly denied. So, of course, there is an underlying mistrust and suspicion of the fact that although people announce very successful outcomes, we don't know what the long-term outcomes are of that because we don't have the data available to us. Deaf individuals have more of an opportunity to see many recipients of these devices, and we have seen many failures. But as far as the data and the statistics that back that up either way, there isn't the kind of ability to get access to that. And really, more studies need to be done to get that data out there. I also want to clarify some information about the deaf community. Oftentimes, we hear it said that the deaf community is against cochlear implantation. And is that the case? It is absolutely not. We are not against that. I even personally have friends that have a cochlear implant. We know of people who have benefited from that significantly, and we recognize that, yes, it is very helpful in some cases for some individuals. What we're left with, though, is a concern, and not just one, but several. What we are concerned about is the fact that there is what we would call the first contact group. When parents have a child who is identified with a hearing loss, the first contact that they have is with a healthcare professional, oftentimes a physician, a clinician. Sometimes there is a different kind of expert. So, for example, in the Idaho educational system, there's an outreach specialist sometimes. Sometimes those are the point of first contact. And so what we hear again and again is that parents are being told cochlear implants are wonderful, it's the thing that's best for them, it will work the best. And so we have parents that assume that an implant is going to completely solve or fix the problem. And that's not necessarily the case. It does require quite an investment of time, effort, and many times it's not something that can be carried through. There's also another concern that, frankly, we have heard that there are parents that have had discussions and already have experiences with the deaf community. Maybe, for example, these are parents who have adopted a child who is deaf, and they have a lot of information that has been given to them that is frankly in error. And when they tell us this information, we decide to, we may decide to ask and find out where they're getting the information from and how that's getting passed on. But when we try to clarify it, we're given a different answer. So there could be a parent of a deaf child, and they get a different answer than a parent, a hearing parent of a deaf child. So it's interesting that we see this different information depending on who the parent is and what their role is within the deaf community as well, whether they have experience, whether they are deaf themselves, those sorts of things. There are healthcare professionals and therapists who really have an attitude of knowing what is best and knowing that they are the ones that, quote unquote, have the answer for this, quote unquote, problem. I know how to solve this 100%. And really, that is completely arrogant the assumption that you have this solution for 100% of the people 100% of the time, it is a level of arrogance that is incomprehensible in some ways. Another concern is the fact that people receive even bilateral implants and then they are sent off to experience that on their own. Maybe they have 1 year of speech therapy and that's all they're eligible to receive. And then they say, good luck, you can move on from there. They don't have that kind of continuum of care. And the people that do that oftentimes don't see the long-term success or failure of the methods that they are using to give people these services. But we see it over the course of many years as members of the deaf community. There's information that we have access to that we can share with professionals. And we, without being biased, without discriminating against TIs, with looking at it as a tool, we have so much that we are able to offer in terms of perspective. It would be wonderful to be able to work together in that regard, to be able to increase the life standard and the quality of life of people who have these devices and these experiences. There are many people that we know of that have implants or other types of assistive technology. Within that large group of people, there still is a need for access, even with all of the devices or all of the technology available. Many times, there are people who say, well, they can read lips or they can write, or there's somebody maybe who will type and put things on a screen to give additional information to meet some of those access needs. And those are things that people have grown up using. So for example, the thumb up, middle thumb system that Steve Snow spoke of before, just that short writing, how are you? Are you feeling any pain? This abbreviated form of communication that requires only yes, no answers, or where does it hurt? Point. That kind of communication does not allow for full expression, does not allow for interaction. And for example, if someone goes to the dentist, and if I've gone and I don't have any specific concerns, but it's just an appointment that I go in to have a teeth cleaning, for example, and the dentist is there and says, oh, we don't need to have an interpreter, or I say I don't have any concerns, and then we have a teeth cleaning. But maybe they say that they don't need an interpreter, but I'm the one who has the experience. I know my situation. So if I make a request for an interpreter, it means that I need to have a more in-depth conversation. There are times that isn't necessary, but when I make that request, it's important. So for example, people like me and also Stephen Snow would like to have an interpreter available in those kinds of situations so that there wouldn't be an assumption that communication is going to be happening another way. If someone asks for an interpreter, it means that they know that they're going to need to have an in-depth conversation. Maybe they want to talk about treatment. Maybe they want to clarify some of the more nuanced questions that they need to ask. There's sometimes questions about abuse that providers ask. Now, can you imagine asking questions like that in writing, where you had a patient write and say, my dad hits me? And then the provider would ask the mom, does the dad hit? And then get an answer of spanking. But that's not what that child means. They're talking about being abused. So that written communication is changing the whole meaning. So when people ask for an interpreter, there's a reason that they want one, and there's a reason that it's necessary. I want to bring up another point about interpreting and that process. Oftentimes people assume that the process of interpreting is a word for word rendering. So we have a famous sentence here: a quick brown fox jumps over the lazy dog. And then below, we have a word by word translation of that. And perhaps some of you in the audience know Spanish. And when you read that sentence, you will know that it is rendered incorrectly, that the translation is not right, but rather the bottom sentence, which I hope is the right one, it could be wrong because of Google Translate, but the full sentence at the bottom could be better, but still other things have to be included. Interpreting also includes cultural aspects. It includes social norms that have to be represented in the interpretation. Interpreters must be content experts, and especially in the area of healthcare and interpreting for healthcare situations. And frankly, not all signers, and many of these people don't have training, so they are not interpreters that should be used in the medical field, in medical settings. And that's the case for other interpreters that don't have specialized knowledge. There's specific terminology that has to be understood. An example that I can use is somebody says, there's a word bus, and it can mean the large vehicle used for transportation. But then there's also a serial bus, where if somebody does not know the difference between those two, they will get a completely different picture about what a bus is in a situation. Interpreters also have many assumptions that they have to make with clients. Now, clients come to us, they have history, they have background, and they come with information about medical terminology or not. One has to determine whether or not they have that information, if it's enough to give them the understanding to follow a treatment plan, for example. And when you think about what will work with the general population, when there's an interpreted interaction, there has to be specific training to be able to do that accurately. Let me move ahead here. Hang on just a second. I just used the example of a word by word translation or rendering, but American Sign Language, typically used by many members of the deaf community, is highly differentiated from spoken language. It has its own grammar, it has its own syntax, it has its own features of language. And I want to quickly just give you a little primer on this prepositions. So in, out, and through. We're going to talk about those for just a minute as a way of example. ASL per se doesn't have those specific lexical items. Instead, we use space. We set up items in space. Here's a building, here's a tree. Then you can show the side of something, the top of something, on top of it. So it's the use of space and the use of visual information that actually makes a preposition. So all of the space that's available is something that we make use of to convey information. We have oftentimes sense of humor. That movie, The Matrix, in that very where they had that scene where they moved in slow motion and the bullets were flying across, you can see the cinematic ability of ASL to explain it. So we also have another joke where there's a deaf person who can be involved in that creative team, if that were the case. For so many years, for such a long time, we've been able to tell those stories because we do that cinematic use of language. We already have that. special effect in our language. It's something that we possess and are able to use. And it's an awesome and amazing language, American Sign Language. You know, there could be other movies that could be added if people would learn to be able to express things the same way that we're able to. So I want to emphasize some other points about the fact of world knowledge and development of information. All scientists have agreed that babies, when they are born, that it's so important for early exposure to language, to sound, to concepts, to information, and that acquisition process is so important and is what leads to fluent language. When people have fluent language use, it means that they're able to analyze, to use critical thinking. They have skills to be able to make associations. All of that gives way to giving more and more information and potential in someone's life. Sadly, for those people who have hearing loss prior to the age of 5, many of them, continuing throughout their lifetime, because of the lack of exposure at a young age, experience language deprivation. Language deprivation has effects on the ability to remember things, on the ability to be creative, on the ability of the brain to work properly. And it's proven that the ability to make associations and to hypothesize is diminished, that it diminishes cognitive capacity. And so, because of the fact that many people who do experience language deprivation, there's a reason for that. It's because of the situation at home. Over 90% of fathers in homes with children with hearing loss do not communicate with their deaf child. And a very large number of mothers who communicate with their deaf child do so in a survival mode, giving commands, go to bed, go take a bath, come over here, eat. So just survival communication, go mow the lawn. And that kind of communication does not have the interchange of natural language, doesn't offer options on how to solve problems or build information on how to do many different things. Also, the educational situation can contribute to language deprivation. The opportunities that children receive. Here's a quote that I have. It says, most, if not all, of our students come in to the school with little or no language. Now, I want to clarify that quote in some ways. We're assuming that it's talking about kindergartners to age 5, and the case is that's not what that quote is about. This quote is somebody who's talking about children of all ages when they come into this school. These are children that go to their local school first, their home school, and then they fail in these environments. Sometimes they're in the 3rd or 4th environment. And then finally in a high school, they're able to come in and have access to communication, but they have little to no language at that time. Personally, our next presenter, Professor Radford and Steve Snow and I have all been blessed that we have had family members, all of us, that have signed since a very young age. We have all been able to have communication access in our homes. And all of our parents were able to understand the needs that we had in order to make sure that those were satisfied. And if we had frustration, we were able to express that frustration so that the situations around us could change. But the point I'm trying to make is that studies have shown that children whose parents who are deaf, these are deaf children of deaf parents, and who have been tested at a range of ages, their language development is on par with their hearing counterparts, with hearing children of hearing parents. Now, for the three of us, we had parents and we had family members who were able to sign. Now, Steve Snow had a deaf brother, but our families were hearing, but the members of our family signed. And still, that was a situation where it ended up that we had access to communication that was on par. Dr. Radford's specific Professor Radford's specific passion does focus on education and language deprivation and meeting the language needs of children. I want to emphasize that our society has failed many deaf people. It is a societal failure that their access to health information and health literacy is terrible. And it is such a tragedy. And the reason that that's happened is because they haven't had access, and then they ask for an interpreter, and those interpreters are expensive, yes, but we're talking about someone's health, and they need it for their health. Interpreters know how and have had the training to be able to help with that communication. They're communicative experts. I want to close with some information about certified deaf interpreters. So we have certified hearing interpreters, who are individuals who can hear English and interpret it into sign language. Those people we call in our industry certified hearing interpreters, or CHIs. Those people have specific training and knowledge to interpret, but there are situations where they are not the best fit for a particular patient. There are many patients who need specialist interpreters, who need really all certified deaf interpreters are native signers, have grown up using that language in extensive environments, socializing, talking with, understanding the frustrations of our people. We understand the linguistic needs, and we know with specialized knowledge how to accommodate what they need us to in order to be able to understand. It's very similar to medical practitioners who are generalists, and then you get referred to a specialist when it's beyond the scope of their practice. It is the same thing happens when CHIs refer clients to CDIs. And you can see here that you would have two interpreters in this picture. One interpreter is providing the services for the doctor and the health professional. And then you have someone who is talking specifically to the patient. Now, I do understand that there is more cost involved in that when you have that specialist interpreter. It's a second interpreter. However, we have people that will say, so my visit fee, the health professionals will say, the visit fee that I would earn at this is not enough to afford the cost of the two interpreters, that it's too expensive and that it's an undue hardship. So the Americans with Disabilities Act, the law requires that people are provided with accessible communication. The word that's used is reasonable accommodation. And medical providers oftentimes will capitalize on that word and say that it's not reasonable in that. But deaf people have had the struggle and the frustration and then have ended up not bothering receiving health care at all. That word, undue hardship, that specific phrase, does not apply to health providers. That phrase in the law only applies to employers when they are going to hire a disabled individual. Case after case in the United States regarding the ADA has been cases has been won when that was the case, that it wasn't an undue hardship. It does not qualify under that. The bottom line is, if somebody says I can't afford interpreter services, not being able to, quote unquote, afford interpreter services cannot be used as a way to say that it's an unreasonable or an undue hardship. That's not the case. So the problem is that the clinic is not allocating enough set-aside expenses to plan for providing accommodations for patients. That should be part of a clinic budget. Just like salaries are paid for and other expenses are met, that is another expense. If you can't pay that, you can't pay the other things. So within the disability community, we oftentimes make the suggestion that all offices, all service providers, all places of accommodation should be setting aside 2 to 5% of their budget to be able to achieve accommodation for all of their patients. So here in the Treasure Valley, it might be that there is more patients. So they would go with the 5% figure. Perhaps in a more rural area where there isn't as many people that are disabled, if it's in that area, you could go with a 2% figure. But the point is if you are not meeting the needs of the deaf person, it's not a budget problem. It's something that you need to be taking care of in terms of accommodation. So the IRS provides specific incentives, and I know I'm almost out of time and probably am over, but during the Q&A, I'm happy to explain more if you're interested in specific tax credits that are available to those who provide accommodations. There's also write-offs that are available, and then there's also reimbursements through Medicaid or Medicare. And here's some more information on what is available. So the law was established to make it so that it is more affordable to provide these kinds of accommodations. And so it is my fervent prayer that you would remember what Steve Snow said, that you would remember the frustrations experienced by deaf patients in situations, and that it's not just them. Do not ignore their need for interpreters. They are people that need the specialist interpreters as well. Make sure that this is available in your offices, wherever you work in the future. Set aside that money for accommodations so that when you have patients that come to you that need an interpreter, that the budget will be ready and you will be able to accommodate them. Thank you very much.
Well, thank you. That is a very passionate plea and gave some very good information, both about the history of interpreting, the need for interpreters, and how that works. So we will save any questions. If Stephen wants to come back on, we do have one question. Otherwise, we'll save it for the panel.
Oh, maybe one or two questions would be okay. I don't want to run too far over on time, but yes, fine.
So we had one question come in. It says, I have seen and read about hearing families only seeking advice from the medical side, and they are completely ignorant to the deaf community and the rich culture behind it. How can we expose them to the right information? For example, that CIs aren't for everyone, that it's not going to fix everything, and that whether or not their child gets a cochlear implant, they still need both languages.
Great. Yes. Okay. As the deaf community, the approach and philosophy that we have is, why would it be that someone would only select one option? Why, once you give someone a hammer, everything that they see becomes a nail? Why not give people an entire toolbox of choices so that whatever is appropriate in the situation, that tool will be available for them? So yes, our deaf community strongly bases our experiences on what we've seen with cochlear implant users, and also through the research that has shown that there are people that have implants, and when they receive speech therapy at the same time, that we can take a look at those people who have exposure to sign language as opposed to those who only have exposure to spoken language. But those people who have exposure to both sign language and spoken language, their understanding and comprehension is increased. There is research and there is information available on that would highly promote the use of all the tools available to any child, and that the use of all tools does not diminish their ability to learn to speak. And so in this sort of medical situation, when you're thinking about young children between 2 to 8 years of age, it is a wonderful idea to include an interpreter so that the interpreter can also provide information. Because by the time a child reaches middle school to high school age, they will start understanding when they can and can't do something. And perhaps at that point, they say, okay, at a doctor's office, I don't need the services of an interpreter, and can make an educated decision. But if it's somebody that has an accent, or if it's a situation where perhaps they're in a great deal of pain, they're not able to focus, or something like that, then at that point, they would say, please get an interpreter. I'm in pain. You know, that it's hard to pay attention auditorily when they're in such pain. And again, when a person asks, there's a reason that they're asking for that service. Don't fight to avoid that. Don't block the access.
Well, again, thank you very much. And we will take another break, and you'll have another poll show up to our participants, and we will start again at 3 o'clock. All right, welcome back. And for anyone who's joining us, I am Emma Wood, your moderator. We have live captioning available by clicking Show Subtitle in the Zoom toolbar. And if you have any questions for our presenters, please send them through the Q&A icon on that toolbar. And then during the Q&A sessions, following the presenter and our final Q&A panel, we will ask these questions that have been sent based on time available to us in our schedule. And I would like to encourage you to attend the final panel discussion so we can get more in depth with some of your questions. Now I'd like to introduce Jill Radford. She's currently serving as a clinical assistant professor in the Sign Language Studies program as an ASL teacher. And she has been many things, a K-12 teacher, a building principal. In any situation that you could teach, she has. She currently serves as the president of Idaho ASLTA and is a member of the deaf community. And as an educator, Jill has been an advocate for providing equal access for deaf and hard of hearing individuals. So please welcome Jill Radford.
Wonderful. Thank you so much, Emma. I will share my PowerPoint with you. One moment. All right. Hopefully you are all able to see my PowerPoint. And hopefully you only see the PowerPoint, not all the notes I have jotted at the bottom for each. One moment. All right. We have enjoyed two fantastic speakers sharing about their experience, as well as providing interpreting services. Much like Stephen Stubbs mentioned, my passion is for education. Since we've had COVID-19 over the past year, I have really felt this need to figure things out to improve access for deaf and hard of hearing students. Many of you are going into the medical field, and I appreciate you staying with me and taking this information and applying it to your studies as well. Some people just think, who is Jill? And some people think of me as an educator. So let me give you a little background. First, I am deaf. But much like Steve Snow talked about his journey as a deaf person, I've encountered many similar experiences. I grew up as a deaf student. In elementary school, I went to my hometown elementary. At that time, I used hearing aids and used my voice. I didn't use sign language. I also had a personal FM system that I used. That allowed me to communicate directly with the teacher. I was able to hear what the teacher was saying, but I couldn't hear any of my classmates. I went into middle school using hearing aids and a personal FM system, and that worked. When I went into high school, I decided to transfer to Idaho School for the Deaf and Blind. I went and was thrown into the deep end, immersed in language and culture. I had always been able to communicate with the teachers, but now I was able to communicate with my peers, and I started to develop my identity as a deaf person. I started elementary school as somebody who was hard of hearing, and I honestly thought I would grow out of it and become somebody who could hear completely. When I entered the school for the deaf in high school, I realized I was going to be a deaf person, and that was fine with me. It wasn't until I was a sophomore in high school I had that realization. I stayed at the school for the deaf for 2 years, acquiring language and learning a lot of information. And then my senior year, I decided to return back to the high school near my home using an interpreter. I did have the interpreter for that senior year as well as an FM system. So I was really able to access information in both languages and have a bilingual experience through my senior year. After graduation, I attended college. I used interpreters for that entire experience. I didn't have an FM system while in college. So that's a snippet of my journey as a deaf student. I graduated with a master's of education in deaf ed. I began teaching deaf and hard of hearing kids, and I taught in a variety of settings. In some, I would work with deaf children who had an interpreter or a support person. Sometimes I was an itinerant teacher. Sometimes I was involved in a classroom at the School for the Deaf, and I've experienced a variety of those settings working with deaf kids. Having seen such a plethora of experiences, both as a student and as a professional, I've had an opportunity to really see the impact of each of those on deaf and hard of hearing kids. Now I am a parent. I have 5 lovely children, 2 of whom are deaf and hard of hearing. Their needs, although there are 2 of them and they have the same parents, their needs are entirely different. I've recognized the need to prioritize their needs over what my preference for them would be. As somebody deaf, I have my own opinions on what would be the best access, so to speak. But I've realized that the best access for each of them is different from one another and different from mine, and that they have different choices that they would prefer. All of that is part of the constellation of who I am. People think, oh, Jill, you think you know everything about deaf education. Well, I may have experienced all of it, it seems. So I hope that you'll take that for what it's worth and realize that what I have to share with you today has some bearing. This pandemic has really highlighted this experience. Throughout my life, I have seen that sometimes the biggest impact is because I am deaf. I go into a room and it is full of people, but I still feel isolated. Often that's because I don't have access, particularly during a pandemic when people are wearing masks, even with face shields. They don't really provide that much access. There is a feeling of isolation that I think we all feel during a pandemic, but certainly deaf people are experiencing. I've asked my husband, is this actually something that I came up with, or did someone else say that? And he said, I've never heard anybody else say it. So I am just claiming this as mine, but if you've heard it from another source, let me know and I will correct myself. Before I proceed, I think it's important for us to share a common understanding of different terminology in regards to deaf education. Some of the terms may be obvious, but deaf and hard of hearing is used for any child who has any type of hearing loss. The term hearing impaired is really out of date. It's old fashioned and not in a quaint way. It's considered offensive. Sometimes there are people who become deaf as senior citizens, and they may prefer to use other terms, but hearing impaired is considered offensive. Hearing loss is still okay, and that would again apply mostly to older people. Stephen mentioned the Americans with Disabilities Act, also called the ADA, and accommodations provided for deaf people. The IDEA, Individuals with Disabilities Education Act, really focuses on access for all children who have disabilities. IDEA uses several terms that come up and are specific to educational settings. One is FAPE, free and appropriate public education, and that's for every child who has a disability. LRE is often called the least restrictive environment, and it's looking what's least restrictive for that child. LEA is the local education agency. Usually it means their home school district. And an IEP is an individual education plan. That plan identifies what the child needs so that they can succeed and to have appropriate education. All of these terms and jargon are all part of IDEA. But it's interesting that IDEA says free and appropriate education. And they say the least restrictive environment is going to be provided by the local education agency using an individual education plan. So the IDEA requires an FAPE and the LRE by the LEA using an IEP. That's ridiculous. Nobody has all those acronyms, but that's what applies to every person who has a disability. So I've explained the LRE and how that often is misunderstood as it applies to children who are deaf and hard of hearing. The most important thing for any child who has a disability is that they are able to be integrated with other students who do not have a disability. That's the concept of least restrictive environment, that children without disabilities are an option and an access for students who have disabilities, that they are with their typical peers. Earlier, I mentioned all the different settings in which I taught and attended school. All of those options are part of the continuum of choices and placement options in regards to deaf children. Many children who have disabilities have a variety of options that could meet their needs, and they can identify what works best. But IDEA really encourages that students be in their local schools with their typical peers. IDEA looks at special classrooms or specialized schools as being more restrictive and recommends those as one of the least popular options. So it encourages students who are deaf and hard of hearing to be around students who can hear. This graph shows a survey of a variety of people and settings and the frequency that they use, the frequency with which they have concerns for language and communication access. Language and communication is the concern expressed most often. The least often concern expressed is in regards to policy or legislation. What's interesting is that the policy and legislation is what really impacts all of the other options that are available. So I showed these circles, remembering that language is focused as the primary problem or concern for any deaf and hard of hearing child. If you keep that in mind, you can see the center circle here is individual, and then it gets larger as the number of people involved increase as well. But at the center of everything is the person who is developing appropriate language. However, the influence goes from the outside in terms of the influence. So the politics influences the education, which influences the community, family, and finally down to the deaf child. During a pandemic, the struggles look different. In my case, I have the 2 children who have hearing loss. Many things have changed over the past year. I've thought about different strategies to ensure each of them is receiving their free and appropriate public education in their local education agency, their local school. I'm not concerned about the local school. I think that they're doing an appropriate job, but I wonder, is that the least restrictive environment? And how do I protect my children from negative consequences of communication access during the pandemic? Whether people can hear or are deaf or hard of hearing, a lot of people are frustrated with the lack of visual access. I can even see my friends who can hear are frustrated by not having access to seeing facial expression. Those non-manual markers are things we all rely on to tell if somebody is smiling or happy or teasing. And with masks, many of us are not certain. If people who can hear feel those frustrations, imagine how it's exacerbated for those who are deaf and hard of hearing. At the School for the Deaf, students have an opportunity to be bilingual and to get access both ways. My daughter Taylor is willing to let me share her story, so I'm not breaking any type of confidentiality. But Taylor identifies herself as deaf and has since she was very, very young. She prefers to use sign language. We've asked her if she would like to attend the local school, and she said yes with an interpreter. And so that's been what she has done. She mainstreams in our nearby school using interpreting services. That was successful for her through elementary and middle school. In high school, she found that she was struggling. And so we talked about what her options might be if she would like to maintain her enrollment in the local school or if she wanted to attend the School for the Deaf. Last year, she was a sophomore and decided that she wanted to go to the School for the Deaf so she could have direct communication in sign language with her professor, with her teachers, as well as be able to take classes at the local high school with an interpreter if she wanted to mainstream for something there. That was really important to her. She is a very smart girl. She's very bright. She does not struggle with academics. When COVID hit, the residential school for the deaf closed, and I noticed that my daughter began to struggle in school. She was feeling very isolated, just as she had when she attended her local school. She was receiving services and had education through Zoom, through Classroom, being provided by the School for the Deaf. She had language access. She wasn't able to be with her peers. She wasn't able to socialize with them in the same way because everyone had to stay home. She felt that her emotional health was not as strong as it had been, and she started to show signs of depression and anxiety. She missed having that direct communication with both peers and instructors. Eventually, the numbers subsided enough that the school felt that they could have students come together again on campus and to remain in small pods. As soon as she knew she was heading back to the school, I could see the benefit. I could see her emotional state really improve. Now, Jordan, my third child, he is hard of hearing, and he identifies himself as hard of hearing, not as deaf. He speaks well. He's able to use residual hearing. He attends a local school without an interpreter. And I have checked in with him frequently. Do you want an interpreter? Do you need an interpreter? And he says, nope, I'm fine. I'm doing great. So that worked well for him until people had to wear a mask because of the pandemic. Suddenly his access to information and visual cues was very, very limited. He came home and said, Mom, what do I do? We called a meeting to talk about what does least restrictive environment look like for him, because he felt very restricted in the mainstream classroom. We requested an interpreter for him, for my hard of hearing son who had never wanted an interpreter. And he said that was fine, but he had never used an interpreter. He didn't know how to access information using an interpreter. So that was all new for him. But between masks and the inability to socialize with peers or interact with his teachers in a meaningful way, he realized that that would be a tool for him to get some new information. So as we started a new school year, he started that experience with an interpreter. He was able to use that, and now he is feeling more comfortable using an interpreter because he recognizes that is another tool that he has to provide access. It is somewhat limited because he's not able to socialize directly with his peers who are wearing masks. And I can see that isolation is really starting to creep in for him. And I've thought, with all of my background, if my two children are struggling during the pandemic, they have parents who support them, advocate, who understand the system, who provide full language access in whatever language they need. Imagine what the impact is on kids and other families. It's time for us to look at least restrictive environment and how that could be interpreted differently for kids who are deaf and hard of hearing. I know that political leaders and educational leaders at the state level and federal level think that it has a different meaning. They think it should mean that children who are deaf and hard of hearing should be in a classroom with peers who can hear. However, IDEA says that we need to consider various factors in regards to deaf and hard of hearing kids, particularly their language needs, their ability to access language in the classroom for both the teacher and their classmates, their peers. They need to be able to communicate with peers. Yes, we know it's important for them to be able to socialize with people who can hear, but they need to have full communication access. And that's not able to happen in a school that doesn't have anyone else who provides the same communication. I suggest that instead of least restrictive environment, when it comes to deaf and hard of hearing kids, we need to look at the language rich environment. And that's the LRE we should focus on. They shouldn't feel there's any barrier to communication. If the pandemic hit and all kids who are deaf and hard of hearing had access to a variety of tools, as Stephen Stubbs talked about, whether it's hearing aids or implants, whatever that may be, but if they also all had the opportunity to sign, that would provide more options. Even if they couldn't access using facial expression because of masks or lip reading because of masks, they would be able to sign and feel unrestricted. Before, you saw that language was the top concern. Now, if we look at this through a different lens, and language is not the problem, instead we look at language mode as a resource, and that children have direct communication access, both to spoken language for for whom it's appropriate, as well as sign language for all, then that isn't a problem. Language is a resource, a support that they have, just as other students have in academic settings. I read a book some time ago called The Tipping Point. The premise of the book is that at some point you'll hit some experience in your life and it will shift your entire life. They refer to that point as the tipping point. I think the pandemic could be our tipping point for deaf education. For many years, deaf and hard of hearing children have continued to struggle academically. They've continued to struggle with being able to thrive and develop appropriate academic and language skills. If they are able to hear some, to speak some, to sign some, they've still struggled because they haven't had full access in all of that. Doctors, nurses, teachers, all need to be providing parents appropriate information on what's going to help their student succeed by being in a language-rich environment. Time is running out, so I want to take a moment and just highlight the most important point that I need to make today. Least restrictive environment for deaf and hard of hearing kids does not mean the local public school classroom. There are many children who do thrive in that type of environment, and I don't want anyone to misunderstand and think that I am opposed to it. But as professionals and as educators, as healthcare workers, we need to ensure that all of their needs are being met. The only way we can do that is if they feel free, confident, and safe to communicate in their language with both their teachers and their peers. They need to know that they are not limited. As Steve Snow and Stephen Stubbs have said, information access is critical, and deaf and hard of hearing children should not be left behind anymore. I have a final quote for you to think about, and every time I read it, I think how important it is to share. Often the first person that parents meet once they find out they have a child who is deaf or hard of hearing is a medical provider. Are doctors and audiologists fully aware of the needs of deaf children or deaf adults? They are not. There are many deaf adults who have said, yes, I went through school and I was successful. Or I went through school at the local public school, or I went through school at the school for the deaf. And they talk about their experiences, but they are ignored. So as Julie Rems-Mario says, she's been deaf her entire life. She's going to die deaf. Regardless if a person uses a cochlear implant or hearing aids, they continue to be deaf. And it's time to recognize that the deaf community, their stories need to be listened to. Their stories need to be respected and analyzed for the universal principles that can enable future generations of deaf kids to thrive. That's the thought I would like to leave with you. It's now time for questions and answers. I can take one or two before the panel if there's something now.
Yeah, if anyone has a question that they'd like to put in the Q&A.
No questions. Perfect. It means I gave a perfect presentation. Go me.
So
I'm just kidding.
we're going to give 5 minutes to take a final poll and have anyone who has some questions, they can think about them put them in the Q&A, and then we will come back at 3:35 with our panel.
Great.
All right. So wanted to thank Jill for her thoughts and her comments. And I think she was able to wrap things very well for us. So one of the first questions, and I'll take this one, is how do we reach you? And so at the end of our conference today, we will send out contact information, and we'll make sure that on your the agenda, conference agenda, we'll have email addresses on there as well. So, and there are a couple of thank yous in the Q&A that I wanted to recognize. So one question is, how can interpreters make an impact for deaf and hard of hearing students and their right to full access, especially for kids who may not have that language background and don't know how to access through an interpreter? Jill, would you like to take that question?
I'm going to read the question in English to ensure that I'm addressing all of it, if you'll give me just a moment. I'm going to give you my utopian answer with Stephen Stubbs here, as well as our qualified interpreters. My perfect vision of education would be to have both a certified hearing interpreter as well as a certified deaf interpreter in a classroom with deaf kids the whole way through. So that's a utopian answer. It's not realistic necessarily. But I know that the role of an educational interpreter is critical, and interpreters need to possess cultural knowledge. That's true both of educational as well as community interpreters. Students who are deaf and hard of hearing in a classroom often struggle with accessing full information and all of the culturally rich information in the educational setting. An educational interpreter is part of the individual education plan team, the group that develops the IEP and recognizes what's necessary to help students fully develop and thrive. Educational interpreters have a role to provide input as an expert in the classroom for educational settings. So that's my thoughts on it.
I'd be glad to add to that. When we look at the word full access in all caps, when I think about that, I think about the classroom environment with a student sitting and an interpreter there. Now, there is passing periods where students have these opportunities to find out what they've done over the weekend, and a deaf student may not have that. People communicate in the cafeteria, and the student would not have that full inclusion. Often, the IEP team, the Individualized Education Plan team, just focuses on this academic and classroom environment. But what they fail to consider is the other activities, the between classes, the cafeteria, the interactions with the friends and after school extracurricular activities. So
Yes.
when we're talking about full inclusion, I'm so thankful that I had my experience at the residential school for the deaf. I wasn't in Idaho, I was in another state. However, when I was done with class, I could talk with my peers, make plans, joke with them, talk to them in the cafeteria. And really, it was just one big wild party all the time. But I was involved after school in sports. And so I had this opportunity to develop relationships, to learn problem solving skills, to develop a sense of self-identity, all of those other things that when you think of the word full inclusion, do they really mean full inclusion or do they just mean inclusion in the classroom?
Thank you. Snow.
Absolutely. There are two things that I would like to add to that as well. It's important that educational interpreters set aside their pride and that they attend workshops and they continue to hone in on their skills.
Absolutely.
Unfortunately, what we see is that many educational interpreters feel that they are competent enough and they don't participate in trainings and they're not involved in the community. And secondly, Stephen Stubbs mentioned the word full access. And it's scary but true. In Idaho, the way that we qualify an educational interpreter is through the Educational Performance Assessment, or the EIPA. And that minimum score to work in the state of Idaho is a 3.5 on that assessment. And that is equivalent to 60% of the message, which means that the interpreter is listening to 100% and only interpreting 60% of the message. And do we consider that acceptable? Meaning that our deaf students are only having access to 60% of their education. If we think about it, 60% isn't a full access to education. Even a 4.0 is still not at that 100% accessible level. It's impossible for a student to be able to fully access their education through a sign language interpreter. They can get close, but it will never be 100%. It's imperative that educational interpreters analyze themselves and that they be honest with themselves about their skill level. Instead of pushing those concerns aside, if they're concerned in some areas, they should be honest and upfront, and they may need to step aside in some situations and have someone else step in to interpret. Many interpreters say that they are good enough and they don't take the time to analyze themselves, so it's imperative that educational interpreters do that.
And that applies to medical interpreters as well. Any situation, really, any type of interpreter, not only educational. Every interpreter needs to know that when they are walking in to an appointment, and I can think how often interpreters may be thinking like, ooh, that's me or that's me. But for a deaf person to have full access, that's not realistic unless the person they're talking to is also using sign language.
So along those lines, what is the best way to establish or reestablish trust with a deaf client when an interpretation has not gone smoothly? And this is from an interpreting student.
I can take a stab at that. That is an issue that we have in one of our classes, in an ethics class, that we focus on really that sort of thing for an entire semester. And it's still just scratching the surface, but really there's two ways to look at it. You can think about the perspective with whether or not the interpreter is transparent with the deaf client. So if they've arrived at an appointment and they say that I'm a novice interpreter or I'm new, and they try to work things out, and they say, if I'm not going to be okay, just let me know and we'll reschedule. You can take a look at that way. Or also, we can take a look at what the deaf person needs. Perhaps it's an emotionally charged appointment, and they know that that interpreter is not appropriate for that situation. But there are those situations that are not that sort. There's a range of situations, and there's a range of interpreters, and sometimes they're layered and they can overlap. One has to think about how to solve that, and it can be discussed at length, but we do actually discuss that for those sorts of things for an entire semester with interpreters.
I'd also want to say in regards to trust, or we're still on that question, correct?
Yes, yes.
Just in regards to trust, I would say that first impressions are long lasting.
Yes.
So when that trust is lost, I would say good luck trying to earn that back. It's very difficult to do. And the deaf community is very forgiving, but it's something that you all should keep in mind, that if that trust is broken and if you have been negligent with that, it's really hard to regain that. We know that interpreters are human, and we will always consider that. There are some situations that are highly sensitive, though, and if an interpreter does come in and breaks that trust, it's very difficult to earn that back. So I would say do it right the first time. Don't make that mistake.
Yes.
I have something else. I saw another question that was in regards to music, a person who had said that they were a music educator. And I thought that that might be, they're talking about accommodating deaf and hard of hearing students. I have to tell you, there are many deaf people who love music. Indeed, there are.
I'm
Yeah,
one of them. I love it.
Especially, well, except me. I don't know. I can't, well, okay, no, not me. But
I
because I can't
love,
hear
love,
it,
love, love, love it.
there are people who do.
Jill's not normal. Just ignore that.
Anything else you want to add about how, let's see where that question went. How to include those that want to experience music in the classroom?
No, I want to go first, not me, or not Steve. I want to go first. Okay.
Yeah.
So in American Sign Language, it incorporates both rhythm and rhyme. Many people don't realize that American Sign Language can incorporate the concept of a beat or of rhythm, that those things are already a part of the language when well done. So if you find someone who is a qualified language model who is doing it well, whether it's music or poetry, there's so many videos that are available now that you're able to show, and that you can see authentic native signers, and they are producing music from American Sign Language, not an interpretation of English music for people who can hear or other languages for people who can hear, but rather deaf poetry, deaf rhythm. Many schools think, oh, we should include sign language. It's so pretty. It'll be very pretty for this song. I would say be careful with that. It is easy to misunderstand how to incorporate signs. Sometimes they're applied incorrectly to English lyrics. So if the goal is just make it a pretty performance, I would caution people against that. So as somebody who is a native signer, I would say bring in somebody who knows ASL. Don't rely on videos for vocabulary.
Absolutely. Another resource that could be used for students or for teachers is called DPAN, D-P-A-N, and that can be found on their website or on YouTube. And they have several videos of music in American Sign Language. One individual, his name is Sean Forbes. I'm not necessarily his biggest fan, but I know he's very popular in that realm. And he makes many videos that are very visually appealing that incorporate those sounds in a visual way. And I wouldn't say many, but some individuals really like that. So that's another option to incorporate music in a visual way.
Thank you. All right, I have one for you, Steve Snow. From earlier, thanking you for your research and the work that went into that. And this individual loves the idea of diversity in the medical field. However, they have witnessed and know of many deaf individuals who have tried to complete a medical program. So as the student, a medical program, but the amount of discrimination they face in these programs is a huge obstacle. So how do we educate the educators?
Absolutely, that's a great question. One of my good friends, Zach Featherstone, he is well recognized nationally for his case of discrimination when he was in medical school. And the National Association of the Deaf actually sued that medical school and won that case. At that point, Dr. Featherstone decided to transfer schools and completed his training there. There are many deaf individuals, like this person asked, that have experienced that and have experienced discrimination to the point where they have not finished. From what I have heard, even after they have submitted a complaint of discrimination, they're often neglected and excused from that program, saying that they don't qualify to finish. There are quite a few deaf students who are currently in the process of going through medical school, so it's promising, but there definitely needs to be more awareness and more instruction for those educators. Unfortunately, autism is rampant in the medical field and in that culture. And what that means is that they are focused on the ear only instead of on the person as an individual. I've noticed some cultural shifts and some minute changes, and I'm hoping that we continue to see that. There are so many competent deaf individuals who can be successful if they choose to enter the medical field. And who knows, one day they could even find cures for horrific diseases, but we need to be able to give them the opportunity to become a doctor first.
If I could chime in with that, we've talked about autism. Doctors and medical professionals often suffer from ableism. They see everything as something broken that must be fixed. I would encourage them to look at it through a different framework. Just look at multiple abilities. So instead of looking at what people cannot do, focus on what they are able to do. When people go in to see a medical professional, they come in with skills, with knowledge, with ability. They aren't coming in as something broken to be fixed. Zach Featherstone's approach in his case are something that the deaf community really celebrated. The deaf community, it feels like one of our own is now in the field that we could get full access. I think, as Steve said, change is coming. You will see a tidal wave of change.
Absolutely. For our participants today that are entering the medical field, I would encourage you to do your part. We can partner together to make that change. Instead of just taking today as just some neat information, you can take this on and apply it to the medical field.
Yes. Often parents meet a doctor as one of their first professionals after they find out that they have a child who's deaf and hard of hearing. They don't know where to find deaf adults, and that's not who they go to first. They trust the medical providers, and so they'll go to the doctor or audiologist and say, "Hey, I have this deaf kid. What can I do?" And I think that this is where medical providers can really establish a rapport with the deaf community, and we're seeing that happen more and more. That change is coming.
So one last comment here. two. One is a thank you for bringing up the idea of 60% with the EIPA. And the other is that hopefully this is the tipping point. And just a big thank you for sharing all of this vital information. And so with that, I'll give a couple of concluding remarks. And so if I'm going to share my screen again, if our panelists want to turn off their videos, thank you again so very much. And I really just wanted to thank so much the time and the energy that's gone into presenting this information from Stephen Snow, Stephen Stubbs, and Jill Radford. And to recognize our Cultural Events Committee here at ISU, who provided the grant money for us to put on this amazing conference. And a couple of final thoughts is that you have been able to listen to various ways that access creates opportunity. And we hope that you're taking away information that you can then apply in your various professions, work settings, family, community, and that you have just amazing experiences with sharing what you've learned today. And I would also like to thank the planning committee for this conference, and Jill Radford, and also Jeanette Olson, who really was the catalyst for suggesting that we even hold this conference. Also, thank you to our tech support, Randy Stam, Lance Rowe, Sheldon Harris, and our interpreters and our captionist. And with that, a reminder that you will have a follow-up email with an evaluation, and please complete that. And let us know what other topics you would be interested in, and anything else that this conversation has sparked. And so with that, we'll say thank you and so long.